Pre-Eclampsia. Now, to help us delve into this, I'm joined by Dr. Edgar Gulavi, who is an obstetrician and gynecologist. Thank you so much, Dr. for coming in this morning. And I must mention just how difficult it is to get time from your schedule, so we do not take it for granted. Now, I'll just begin off by perhaps giving a few statistics so that the audience really understands what, preeclampsia, or how far preeclampsia has stretched. Now, pregnancy-related causes that lead to maternal death stand at 355 deaths per 100 live births. 355 deaths per 100 live births. Now, for preeclampsia only, in Kenya, the rate is at 0.3%, while the prevalence rate or the commonness is at 6.1%. So you might think it's just 6.1, but it's a big 6.1%. And so that will perhaps kick off the conversation for us this morning. So, Dr. You have been at the center of the whole action. Basically, you work in a labor room, or you've really had access to women and just had to deal with these cases often than not. Well, I've not been in it just yet, but I've had friends who have been in the room, and just how fast things can turn around. And when somebody stands and says, I've had preeclampsia before, eyebrows sort of curl. People don't know what is that, what is that. So perhaps that's just the best status of what is preeclampsia.
Thank you, and thank you so much, Cynthia, for the invitation, and I'm glad to be here.
You're welcome.
I think that's what we sort of need to break down into sort of a simpler way to look at it. When we talk about preeclampsia, it's a big word, but really what it basically means is high blood pressure that develops after 20 weeks of pregnancy. So an easy way to look at it is when you have high blood pressure before you get pregnant. There are people who have high blood pressure before they get pregnant, and there are those who develop high blood pressure when they are pregnant. So if you get pregnant and you develop high blood pressure after 20 weeks of your pregnancy, so about halfway through, then we call it, we can categorize into different categories. It can either be what we call gestational, or it can be preeclampsia. Now, preeclampsia is the sort of severe form of that high blood pressure in pregnancy. Gestational hypertension is the one that is not so severe. It's not associated with damage to the organs that of the mom's organs. Today we are really focusing on preeclampsia. So what is it exactly? It is a multi-system disorder. What that means is different systems are affected in the body. So the brain is affected, the kidney is affected, the liver is affected, the blood is affected, and definitely the baby is affected by this. So it's multi-systemic. Okay? That's the first thing that we need to understand. So most people will always ask, where does it come from? I was okay before pregnancy.
Very healthy.
I was healthy. We've never heard of this thing, and now I have high blood pressure now that I'm pregnant. The truth is, unfortunately, it's not a very well understood condition. What has been thought is that as the baby is forming, there's something called the placenta. So that placenta is supposed to invade into the mother's womb, the uterus, and therefore to be able to supply oxygen and blood to the baby. So sometimes as the placenta is invading into the mother's uterus, it doesn't do it so well, such that this leads to what we call disordered placentation, and therefore this now causes you to release some substances in your bloodstream that now increase the blood pressure. So a bit complicated, but to break it down simpler is that as the baby is developing in the womb, the placenta does not develop properly together with the mother. It doesn't attach properly on the mother's womb. This causes you to release some substances that now increase your blood pressure. That's one of the things that has been thought to be the cause. But to say that this is exactly the cause, it has not been all over the world. Unfortunately, this is something that has not been found.
Yeah. Now, you mentioned about, it being a kind of a high blood pressure that, women get after the 20th week or 20 weeks of pregnancy.
Correct.
So I'm really trying to understand, this means, whether or not you have high blood pressure, without, at the moment when you're not expectant, with or without high blood pressure condition, this is something that eventually grows into you. So is it just exactly 20 weeks of pregnancy, or could it come earlier than that?
All right. So that division now comes in. That's a good question. So anyone who has high blood pressure before they're pregnant, we call it chronic hypertension. Right. So people who have chronic hypertension are those ones who have high blood pressure even before they get pregnant.
Yeah.
Now those people, of course, are at a higher risk of getting pre-eclampsia, which is now the blood pressure after 20 weeks with systemic effects.
Yeah.
All right. So the brain, the what, all those things. So if it was not there and then it developed in pregnancy, now that's pre-eclampsia. If it's there before, that's chronic hypertension. So that different sort of is very important. Which also now brings us to talk about the risk factors.
Yes.
All right. So you've brought out one of the risk factors. Risk factors basically is what are the things that would increase the likelihood of you developing high blood pressure in pregnancy.
Yes.
One of them is what you've talked about, basically the risk factors for developing pre-eclampsia. One of them is having high blood pressure before you got pregnant.
Yes.
So chronic hypertension. That increases the chances of you, getting the pre-eclampsia. Another risk factor is their genetic composition. Okay, there are some genes that are in families that increase the chances of someone having high blood pressure in pregnancy. So if your mother, a sister has high blood pressure, then the chances of you developing high blood pressure as well increase. All right.
But that doesn't necessarily mean that you'll also have high blood pressure if it's in the family.
No, it just increases the likelihood that you will get.
Yeah.
Even up to 5 to 6 times the chance. So look at it this way: if one family does not have and your family has, if you compare the two, then the likelihood of you developing in your pregnancy is higher because of that genetic composition. Even for men, it also men can also contribute. Meaning, if, for example, let's say your spouse is born from the mom, your mom, when your spouse was being born and the mom had high blood pressure, then the likelihood of you developing high blood pressure because of your spouse, also increases.
Is that something that is scientifically interludes, or what is it?
It is an issue of the sperm, basically. The sperm also carries some genetic material that increases the chances. Now, so those are one of the risk factors, genetics. Things like first-time moms. First-time moms are more likely to develop this than not. If you are older also, if you are very young and if you are very old. So if you are 18, some people get pregnant when they are very young. If you are very old, above 40, that also increases the chances of high blood pressure developing. All right. Things like high BMI. So if you are obese, that increases the chances of you developing. If you have other conditions, diabetes, things like autoimmune diseases, kidney diseases, those also increase the chances of you getting preeclampsia in your pregnancy. So what we usually say is, before you get pregnant, ideally, you should have a sit down with a gynecologist, look through your risk factors, see if there are things that we can modify before you get pregnant to reduce the chances of you getting the preeclampsia. There are things we can't modify, like genetics, but there are things like obesity, those ones we can sort of try to modify. Or even if you have high blood pressure before you get pregnant, we can try to control it. By the time you're getting pregnant, your blood pressure levels are low, you don't develop the preeclampsia.
Yeah, and you've mentioned one critical step that I think a lot of people do skip.
Yes.
Either before you decide to become a parent, even before you decide to get married to this particular person, you should always visit an OBGYN so that, they're able to identify these pieces out. Now, there's a very interesting scenario that I've come across, and perhaps it has got something to do with missing that doctor appointment. A lady had the first spouse. Good, no complications, pregnancy all the way to, the birth point. But then the second pregnancy sort of changes and she has got these problems. I mean, how do you explain that? And, the first pregnancy, fine, no problem. But the second one has got the preeclampsia part. How do you explain that?
Yeah, I mean, those are some of the things that, we are talking about. Of course, each pregnancy is different, all right? One pregnancy not having preeclampsia does not mean the other one will not. As you grow older as well, the quality of the egg also changes, all right? So that also affects you yourself, your age changes.
Quality of the egg, like the woman's egg?
Yes, yeah. So as you age, women have the quality of the egg changes. Basically, when I talk about quality, I mean the genetic composition of the egg changes as you grow older. So of course, when someone was pregnant, first pregnancy and second pregnancy, you yourself, you have also aged. So that also contributes to an increase in the risk of you getting the preeclampsia. Things like obesity developing, things like that. So there are many risk factors that might increase from one pregnancy to another. And therefore this would can happen that you don't have it in one, but you have it in another.
Now that you've explained, what preeclampsia is and how it comes about. Now the question of how do we pinpoint it out?
Correct.
How do we know what are these signs and symptoms as well? If you can talk on that.
So really, one of the things we do as you go through your pregnancy journey is we are looking out for any complications. So every time you're coming to the clinic, of course, we sort of try to tease out if you're having any issues. So we check your urine, we are checking your blood pressure, how you're doing, your weight gain, all these things. So those are some of the important things that you're trying to pick out when you're coming for the antenatal clinic. So these clinics are very important. And most times, you end up doing it every month. You're coming to see the gynecologist. It's not just coming to say hi, it's also us trying to pick out all these things. Now, there are those things we call symptoms. Okay, symptoms are the things that now you will develop if you have this high blood pressure. Majority of the time, most people will come with if you start head to toe, because it's a multi-systemic condition, then it can affect everything from the head coming down. So if you say the brain, it can affect the brain, meaning you can start having things like headaches. So that comes from things that now sort of develop because of the amount of blood going to your brain. You can start having issues of vision. Okay, so sometimes someone wakes up and say, I can't really see well, all right, because of the effect of that high blood pressure. We, in big terms, we call it visual scotomaters. Okay, so you're not seeing well, you're having severe headaches, you're taking a painkiller, it's not, it's not going away, that headache. So that's one of the things that start. Now when you come towards the chest, all right, things like breathing difficulties. What usually happens is fluid can accumulate in your lungs such that you're not able to breathe properly. All right. If we come down, then we're having the liver. The liver is on the left, on the right side of just below the ribs, basically. So high blood pressure can affect the liver such that you start getting pain just here, just below the ribs, at the center point, and also on the right side. Right? So we call it epigastric pain. Right? So that can be quite severe. The other symptoms which are a bit difficult to elicit, but for us, is that the baby is not growing as well as they should, because the amount of blood going to the baby is also affected. Most common presentation is usually swelling of the limb, of the legs, hands, face. Actually, that's one of the most common things. Someone wakes up and says, "Oh, my spouse told me my face looks swollen." Yeah, when they come to the hospital, we do a blood, it's raised because of that fluid accumulation. So basically, significant weight gain more than usual. Swelling of the legs, hands, face. So those are some of the things that patients usually complain about and present with. And those are some of the things we, even as we're coming to the clinic, we are looking at.
So just let me just cut you short a bit. There's the issue of the baby not growing so well in the womb, and that is something I cannot identify.
Correct.
Not unless I go to the clinic and have an OB take a look at. So how are they not growing well? I mean, is it that some of the features are not coming up properly? What are we
exactly
talking about?
Do you mean? It's a good question. So now we're talking about the things we call signs. So because the blood pressure is affecting the amount of blood going to the baby is smaller than what we would expect. Right? The amount of we call it amniotic fluid. The amount of amniotic fluid being produced is also affected. So really there is nothing anatomically wrong, meaning the baby is, the anatomy of the baby is okay. The brain is there, the lungs, all of them are there. It's just that they are not growing. They are not growing in the, in the way that you'd want to grow. So for example, if you are, let's say 30 weeks pregnant, or you're in your 7th, 8th month, the baby is supposed to be, let's say, 1 point something kilograms. You find your baby is 500 grams, So that means this baby has not been getting the nutrients required to grow at their size. The other thing is the high blood pressure also affects kidneys, because the amount of blood going to the kidneys is affected. So the kidneys also start struggling in terms of their functioning. They are not processing, removing the toxins, so you now start getting issues of that, and also that retained fluid and swelling of the limbs. The blood pressure also starts affecting your blood, so issues of clotting, you get clotting issues. There's a component of the blood called the platelets starts going down. All right, so you end up having increased risk of bleeding. All right, so these are things that we pick up. So you'll pick up baby is not growing well via ultrasound. You'll pick up the kidneys are not functioning via blood test to check the kidney. You'll pick up that the liver is also struggling by doing liver function tests. We'll do a blood, call it a full blood count to see the platelets and the hemoglobin. All right. So those are the things now the doctors will elicit to see the severity of the condition. Pre-eclampsia is also sort of classified in terms of severity. There are those who have pre-eclampsia without severe features, and there are those who have pre-eclampsia with severe features. Right. Now, the severity of that classification will determine the next step. If someone has pre-eclampsia without severe features, then you can sort of buy some time, because the treatment for pre-eclampsia is actually delivery. Right? That's
you just have to bring the baby out. You have
to deliver the baby. But now most times you find that someone might develop this condition when the baby is still premature. So what we are trying to see is how far can we push you towards the end of your pregnancy without compromising your health, but trying to keep the baby safe. So that's the balance. Now, that classification of without severe or with severe features helps us, because if the condition is very severe, it's affecting the mother's organs, then that one we don't have a choice. We just have to go ahead and deliver. All right.
Now, while doing a lot of research on preeclampsia, as I prepared for this, I also came about something called eclampsia.
Correct.
And I couldn't really, try to pick out what are those tiny bits of details between what the difference really between the two, because both of them, it's all about high blood pressure, isn't it? So what is, different from preeclampsia and eclampsia?
So you can tell that pre is before eclampsia. That term comes from the eclampsia. So what we fear most is that term eclampsia. Eclampsia means seizures, a mom developing seizures when they are pregnant, and most times it's because of the high blood pressure. Right. So the amount of blood going to the brain, like we've said, it's a multi-systemic disease. The amount of blood going to the brain is affected. So, or the mom develops something like cerebral edema, a fluid in the brain basically, or something like a stroke in the brain. So what then happens is the mom goes into fits, all right, like the ones you see in the movies, or they start having seizures. That one is called eclampsia. So seizures in pregnancy is called eclampsia. Now, because it comes over the world, really, everyone is looking at how can we reduce preeclampsia and how can we reduce maternal deaths because of preeclampsia. So one, of course, is early identification of risk factors. So that's one of the things we've talked about, and that involves something we call preconception counseling. Right? So you have something called preconception counseling. Okay. So basically what that means is you coming to the clinic before you even conceive. We have a look at your risk factors and then advise you on how to, because there are things that we can do before you conceive and after you conceive that could help to reduce the chances of you developing.
Is it to say that majority of women who don't go to the clinics pre-conceiving fall victim to preeclampsia?
I wouldn't say that, but I would say that on a very small number or percentage of women actually think of going to the clinic before they conceive. Most conceive and then come to the clinic. Which is fine, and even in terms of statistics, the more that we give. So that's the one that has really been
this for a bit, the age factor. I don't know if you've heard of this, but there's a popular sprinter, somebody that traces 100-meter. So basically the sort of exercise they're doing, you term this person completely healthy. At the age of 32, passed away during delivery due to preeclampsia. So, is age a factor? Is it proven that perhaps from this age to this age, majority of them might be victims of this, and then there's a particular age group that are likely not to really much be affected? Is age a factor in preeclampsia?
Yes, age is a factor. So the younger you are, the higher the risk that you can develop it, and also the older you are. So we're looking at between 18 and 21 if you get pregnant around there. And also if you're a bit older, be above 40s, that increases the chances of you getting pregnant. Now, specifically about the sprinter, I mean, once you develop it, it doesn't matter whether you are, a sprinter or what. It doesn't really matter, because once you develop it, we need to manage it. And you see, if these complications arise, then they can lead to death. So think about it. Even if you are a sprinter and you developed, a clot in your brain, at the end of the day, that it doesn't matter whether you are a sprinter or not. The important thing is identifying it early, managing the complications, and trying to get the baby to as far towards your end as possible.
Yeah, and we've focused mainly on women, so we can talk about the men a bit. This is your spouse as a man, and she's gone to delivery, and then it hits you, it's a life and death affair.
Correct.
Do men accompany women to these clinics to understand what this preeclampsia is? Are they aware of what this is? Because I feel like, it's sort of like a woman issue. You deal with it. You're the woman, you're the one carrying the child, so deal with it. You need to know when to go for the appointments, what to eat, how do you ensure that you're looking out for these signs? But with the men, are they on the same page here?
Yeah, I mean, ideally, there has been an increase in terms of the role that men play, all right, and that's one of the most important things. Actually, spouses accompanying and even partners being present for clinics, being present for delivery. Research has actually shown that there is significant effects of that. All right, so basically in terms of women feeling supported, understanding the journey, and even in terms of labor, reduces the chances of C-section, the requirements for pain. So yes, there is a role for men to be present and to be active, and there has been an increase in men who participate in the pregnancy journey of their partners. And this is something that I always encourage, and because research backs it.
Now, in Kenya,
coming to clinic, is it a transport issue? Is it identification? Is it attending clinics? Is it financial issues? Because sometimes in other communities you'll find the partner is the one who is the one who says, okay, now go to clinic, take this money, go to clinic. So community plays a role. And then there is the hospital healthcare. Now the infrastructure plays a role. For example, if I tell you now we need to do your liver function test,
yes,
but the infrastructure to do liver function test is not present. So how do we monitor the severity of your condition? It's the infrastructure. And then now of course there is the health worker. Of course, how does the health worker impede or help in managing this condition? So you see, healthcare is multi-pronged, and you can't look at it from one perspective, but there is a lot of effort from everyone, from the healthcare workers, from the infrastructure, or from the community, to try and improve the coverage, as well as improve on financing. Now we're looking at NHIF and what NHIF can do in terms of offering holistic care to the women, without having issues of finances. There's still quite a lot of work to be done.
I will just take on that a bit, because if you look at these symptoms, you talked about the liver, so you need something that identifies there's a liver problem. The scanning machine to keep tabs on the baby. So how expensive is it to treat preeclampsia? It's not. It's different from a normal pregnancy, because for the normal one, perhaps you'll just see your doctor a couple of times before you give birth. But for preeclampsia, it's almost as if you need to be under 24 hours medical supervision. If not 24, then I don't know how many hours, but you need to be sort of under a doctor's supervision all the time, because it's high blood pressure. So how expensive is it to treat this particular condition? You're right. It's quite an involving pregnancy. The trajectory is not like the normal pregnancy. You'll take a tangent. So it depends. If you're being managed not in the hospital setup versus the hospital setup. If it's outside, of course, then there are more frequent clinic visits, more frequent ultrasounds and blood tests. You'll be on high blood pressure, lowering medication. So the amount of money you spend, even out of pocket from your insurance, whatever, will be definitely more than the normal. We're looking at, even if you're going in for a delivery, let's say push comes to shove, you have to deliver the baby, and the baby maybe comes out as a premature baby. You see, a premature baby also requires a long stay in hospital, oxygen, in their drugs that they need to be given. It's quite an expensive thing. All right. So that's why we try to limit the people who get the preeclampsia. Once you get, we try to manage it in a way that you don't get complications.
if you do get complications, then we try to manage you in a way that you don't end up, in worse of a situation than you already are. So there are those steps that we take before you conceive, when you conceive, if you develop high blood pressure, with severity, if we require to deliver. So we have to, in each of these, we have to find something that works for you and for us.
Yeah. And I know you might have the answers to this, but we have I use the common insurer, which is NHIF. What does NHIF cover? What does it not cover?
Okay.
Yeah.
I mean, the truth is, that's a difficult question to answer because the NHIF has different contracts with different hospitals. So you'll find, in the government facilities, it will be able to cover maybe X amount. Majority of the time, most of the things there. If you go to a maybe faith-based hospital, the contract is different. Maybe it will cover X amount. So it's a difficult question to answer, and I think it depends on which level of facility you're going to. That will determine the amount of it covers.
Now, let's talk about the baby that in this instance, is in the womb of this mother that has preeclampsia.
Yes.
It must be really tough for this young one in the stomach, because when the mother suffers, the child suffers as well. So how much does preeclampsia affect the baby? We've talked about what it does to the mother. What about the child now who is in the womb?
Okay. So this child is actually at risk. They are at risk of, what we call fetal growth restriction. Basically, they're not growing as well as they should. They are at risk of something we call abruptio. Basically, the placenta separating earlier than what you'd want. So fetal death is actually one of the things that we really worry about, and that's one of the things that can happen to the babies. So they are at risk of earlier delivery. So prematurity and preterm birth is actually one of the things that can happen. But generally, if we are able to manage the condition and we are able to end up with a good delivery, the baby comes out, then the babies are quite hardy actually. Because of that stressful environment, the babies become quite resilient. All right. The other thing is they don't end up having, if everything goes well, then even if they are smaller, they don't end up having long-term issues. Things like lower mental or with cognitive ability. They'll still be able to do their things. They'll grow up well. They don't have any long-term issues if we manage the condition well and they don't suffer any acute issues. So someone shouldn't be worried that I had preeclampsia, now my baby will not go to university or something.
So so there is no possible way that a child who's been in the womb during the preeclampsia problem with the mom will have any sort of health risks post delivery.
Definitely some of them do end up having, because of that they end up having some risk factors, cardiovascular issues, such things in the future. But so that one is dependent on many things. It's not because you had preeclampsia now you end up that environment plays a factor, how the baby grows up, diet, all those plays a factor. But yes, they do have an increased chance of getting cardiovascular issues later on in life.
What about the mom? Because after this you meet the mom and it's like nothing ever happened during the pregnancy, almost as if back to normal. What about her? Is there anything health-wise that she risks post the pregnancy?
Yeah, that's a good question. You'll find most times that the high blood pressure, if it was not there before, goes down after delivery. So the high blood back to normal. In the subsequent pregnancies, there is increased chances of it coming back again. All right, so that's also something. Sometimes the high blood pressure doesn't go away, so you develop chronic hypertension. throughout your life.
Yeah.
Right? So there is chances of that happening. There are also chances, of kidneys, if they are affected during if it's very severe, that's something that can happen. There are chances of, cardiovascular heart diseases. Those ones also increase with time. But I would say majority of the time the blood pressure goes down, and we are able to not have you get those issues in the future.
Yes, yeah. Now I'd love to take you back a bit, because you talked about this fetus that is likely to be born prematurely. Are there instances where they are carried full term, these babies, and if so, then what happens in the labor room, just as a precaution?
Okay.
Yeah.
So yes, preeclampsia can develop any time, 20 weeks after you're pregnant. So it can develop maybe when you are 23 weeks, 24 weeks, all the way up to towards. Some people also develop it after delivery.
Oh, really?
Yes.
Yeah.
Now, it depends on how far you are in your pregnancy and how severe. So we've said there are those who have without severe features, those who have with severe features.
Yeah.
So if it happens towards the end when you're about to deliver, it's a bit better, because we are able to deliver the baby and we are sure the baby is fully formed. In terms of delivery, we have two modes of delivery, either vaginal delivery or a C-section, depending on how severe the condition is and how your kidney functions, liver functions, blood tests are. Then you can go either way. We can either induce you to go into labor and deliver, or you can have a C-section. So that it depends on how.
Yeah.
There are many factors we consider when you're making that decision. But what we end up doing is that the delivery is what sort of helps us to manage the condition.
Okay.
Yeah.
So I'd love us to take a quick break, but when you come back, Daktari, there's something peculiar. I don't know whether it's peculiar, but I came across about race. It is, according to statistics done in one of the universities in US, it says that black women are more likely to experience preeclampsia rather than white women. I don't know about that. So when you come back, we'll be talking about that and just see whether age is a factor, so race is a factor as well. So that is the question we'll be answering after the break. So keep your feedback coming in. Any questions, concerns you'd have to ask, Daktari is here. He will be answering them when we come back after the break. Stay with us.
Hello, praise the Lord. My name is Pastor Joseph Musajawaza of Unfailing Love Ministries. I'm inviting you every Wednesday to join us on our program, Victory Through the Word. In this program, we teach you God's Word. We teach you to find solutions and answers to the struggles of life through the Word of God. Everything you ever go through in life, every pain, every tear, every worry, and every questions that you may ever have in this life. You may not get answers out there, but in God's Word, there are answers and there is a solution. The Bible says that God has exalted His Word above His name. In His Word, there is hope. Heaven and earth shall pass away, but His Word will always remain abide. I encourage you, engage with us as we study together, as you ask your questions, and let your questions be answered as you are built and as you hear God's Word. Our church is located in Umoja, Inako, near Olobon Hotel, just off Sango Stage along Moi Drive, and the court is known as Church Court. Give us a visit and your life will not remain the same. God bless you. Let's meet every Wednesday from 7:30 to 8:30 p.m. only on EBN television.
You are watching EBN TV, transforming your world.
So welcome back and thank you for staying with us. You are watching Morning Live. The conversation continues on maternal death, and we're focusing on preeclampsia, which is one of the top causes of maternal death in Kenya, not just in Kenya, but also across the globe. Now, we began this conversation and I mentioned a few of statistics, so I'd love to repeat them again. Pregnancy-related causes that lead to maternal death stands at 355 deaths per 100,000 live births. 355 deaths, which is quite a huge number. Now, for preeclampsia, 0.3% of death rate in Kenya, and the prevalence rate is at 6.1% in expectant women. Basically, the commonness amongst expectant women is at 6.1%. Now, my guest is still in studio with me, Dr. Edgar Gulavi, who is an obstetrician and gynecologist, has been able to explain what preeclampsia is, you know, the signs and symptoms, how it comes about, how it is diagnosed. And now, Dr. Gulavi, before the break, I talked about the race factor.
Yeah.
Now, according to statistics, well, I was just going through some of the key issues. It talked about a black woman and a white woman, racially speaking. And it stated that, you know, black women are accustomed to be more affected with preeclampsia rather than white women. I mean, how so? Is this science?
Yes.
Yeah.
So unfortunately, that's one of the things that has been seen. Minorities like you know, blacks, Hispanics usually ends up having higher risks of the preeclampsia,
Yeah.
and when they do, the outcomes are not as good as Caucasian. Of course, this has something to do with access to healthcare. These are something to do with things like that. But in terms of why the race issue it's a genetic issue. There are some, you know, genes that have been identified that sort of increase the chances of black women having it as compared to Caucasian. And therefore, in terms of the outcomes, because generally black women and minorities end up not getting the proper care that they should, then of course issues of maternal death, poor outcomes for the babies, all these now come into play. So yes, race is a
factor. So when you talked about, you know, what to look out for, you talked about genetic composition, diabetes, kidneys. So the racial part is also a factor.
Right there, yes.
But for Kenya, you know, it's more of like we're all sort of the same. You know, how would I put it?
Yeah.
We're all sort of the same race.
Yes.
You know, with instances, of course, with visitors that have come into the country. So does this really play a part in Kenya? Does it have a role in Kenya, the statistics of?
I mean, if you were to ask me if there is a particular region in Kenya that has more preeclampsia, you know, generally it's pretty widespread. All regions have. How we look at it is basically almost up to 10% of pregnancies will have preeclampsia. So if let's say in 100 women, 10% of them, 10% of them will have the preeclampsia. So we don't have a regional sort of difference. Yeah.
So there's no question of, you know, whether you come from a you know, well-abled background or whether you come from a vulnerable background. It really makes no difference.
No. The thing, it will make a difference if maybe now things like, you know, calcium and you know, regions that have low intake of calcium, now things like that. But generally, the regional difference is the same.
All right, so as we wind it up, I'd love to take a few questions that have been sent in. There's one who asks, how can one prepare their body for pregnancy in terms of nutrition and physical exercise and such? Also, should one go for tests before planning to get pregnant?
Yeah, I think we've talked about that. We've said at least we should have a visit with the doctor or with the gynecologist as you're thinking of getting pregnant. This helps us to identify some of the risk factors, to modify some of them. You know, something like, you know, if you have diabetes that is not well controlled, if you have chronic hypertension that is not well controlled, we need to get all these things better controlled before you get pregnant.
Yeah.
We are looking at if you're obese, you know, if you're obese, that of course also has, we have to sort of modify that before you get pregnant. Nutritional issues, there are people who smoke, they take alcohol. Nowadays we have people taking a lot of recreational drugs, weed, what. So also we need to modify that before you get pregnant. And then just generally have a look at your nutrition and see, you know, how are you doing any exercise. We do a lot of sedentary lifestyle, sitting, no exercise, no exertion. So also that sort of we have to look at and try and modify. So the things we can modify, we really need to modify them before you get pregnant. The ones we cannot, we hope that what we've modified, you know, will help.
Yeah. There's also one other who says, you know, if Daktari could talk more about the spouse factor and how, you know, the sperms, I believe, you know, it mentioned to do with the spouse factor as well. Says, you know, if you could talk about it once again, not more once again.
No, you know, that's something that just was discovered, that you know, if your spouse, when your spouse's mom was pregnant and if she had high blood pressure, it is possible that, you know, some of that is passed through your spouse to you, and therefore you can end up having high blood pressure because of the contribution of your spouse. All right. Yeah. So that's something that was sort of discovered. That's not something you can modify, of course, unless you get a new partner. So new partners have actually been, for people who develop high blood pressure with one partner, several, maybe you lost a pregnancy or another one, you know, having a new partner actually can modify that risk factor.
That's very interesting.
I'm not advocating for people to get new partners.
I almost asked, what about someone with several
partners? Yes. So yeah. So now, of course, but you know, you can't go asking your partners, oh, did your mama have that?
So how do you establish, you know, whether they from their side of the family they've had that, you know, a history of high blood pressure? How do you identify that?
No, that's something you get from history. From the history. So, you know,
so it's just a conversation.
It's a conversation.
My mom used to have.
Yes, correct. So it's difficult, you know, if it's not someone who you are in a long-term relationship with.
All right. So as we wrap it up, Daktari, perhaps you can just have the final word on this preeclampsia issue, and just the rate at which it's a maternal, it's the top cause actually of maternal death, as well as the civic education that we need to have, not just as women, but also generally both men and women need to have on preeclampsia as we wind it up.
I think let's try our best to have, when we're thinking about getting pregnant, let's have a pre-pregnancy visit to our doctors. Let's modify the risk factors that we can modify. If we develop, let's attend clinics once we get pregnant, so as to be able to identify the high blood pressure if it does come. If it comes, then let's be able to treat it in a way that, you know, it reduces the chances of having poor outcomes for the mom and the baby. But if all these things happen, then we try our best to manage the condition based on how we are. So I mean, pregnancy can be unpredictable journey, but we do try to help, you know, as best as we can as we go through the journey with you.
All right, thank you so much, Dr. Edgar Gulavi, an obstetrician and gynecologist. Perhaps we should also assure women that, you know, pregnancy can be such an exciting journey.
Correct.
Yes, so it shouldn't really, scare you
No,
to the
not.
extent. So thank you so much for coming in to shed more light on the preeclampsia part, as well as eclampsia, the difference, some of the risk factors you need to know. What is it about? How do you go about it, particularly when you find yourself in that position within the pregnancy period? So that is the conversation that we've been having today. Thank you for your feedback that has been coming in and your questions as well. The conversation can keep going. If you have any questions, always leave it and we shall be able to engage Daktari here, and perhaps you can get an answer later on. So that's it for this morning. My name is Cynthia Nanjala. Have yourselves a wonderful day. Thank you so much for coming in.
Karibu, thanks.
Yeah.
Thanks.
Thank you.